Once again, welcome to Dialogues for today and good evening. I'm Malavika Subramaniam, and I'm very happy to welcome all of you to what promises to be a very exciting talk and a very timely topic about public behavior during the times of the pandemic. We have two very distinguished speakers today, and I'm going to look at my cheat sheet and make sure that I share all the information that I have with you about them. We have Dr. Soumi Roy Chowdhury with us. She's a consultant and was formerly an associate fellow at the National Council of Applied Economic Research in India. She completed a Ph.D. in economics from the University of New Mexico. She's an applied researcher and she has experience in conducting and supervising field research primarily in India and Nepal. And the research interests are mostly in the areas of health, development, and gender issues. Soumi has been working on multiple interdisciplinary research projects, such as the impact of air and water pollution on health, alcohol taxation rates in India, local governance and financial autonomy of Gram Panchayats, among other projects. She has worked closely on contingent valuation methods for a doctoral dissertation topic on the socio-economic consequences of cancer. This was based in Nepal. She has collaborated with researchers from World Health Organization, American Cancer Society, Tata Center for Development at the University of Chicago, and other ministries at India as part of various projects. And her research has been published in several leading journals, including World Development, Public Health, Journal of Health Management, among others. She regularly contributes also to opinion pieces and blog articles, blog posts in various outlets such as Indian Express, The Print, Ideas for India, and so on. We also welcome Dr. Shantanu Pramanik, who is a senior fellow at the National Council of Applied Economic Research and is the deputy director of the National Data Innovation Center at NCAER. He's a statistician and survey methodologist by training, and his interests lie in survey methods, data quality, remote monitoring of data collection activities, randomized controlled trials, small area estimation, and the application of these methods across different substantive domains, including vaccination, health insurance, which are related to the topic of today, especially the vaccination piece, and also health expenditure and family planning. Prior to joining NCAER, he worked as a research scientist at the Public Health Foundation of India and was a survey statistician at an ORC, an independent affiliate of the University of Chicago. Thank you both so very much, and please take it away, all yours.
Yeah, so I will start first. Let me share the screen.
Are you able to share the screen?
Yeah, I can.
Okay, great. Yeah, thank you.
So it's visible, right?
Yes.
Okay. So thank you, Dr. Malvika and Dr. Sengupta. What we will and thank you everyone else who joined. I can see many of my colleagues from NCER, including Sonal ma'am here present. So what we thought of doing for today's talk is we'll actually wanted to see how this the COVID appropriate behaviors or the protocols for as of now and the time that we are in. I don't think what are the protocols and what are the protective behaviors needs any more introduction, but I'll go into details during the talk. So what we basically wanted to see that how this COVID-19 protocols have changed over time, how people have behaved or changed their behavior as and when the peak started coming, the first wave, and then the wave 2 started coming in, before the wave 2, during the wave 2, and even after that, recently what we are seeing. So this kind of the trend, as we say it, like we wanted to see that temporal trend and how that is changing. changing, and also the vaccine hesitancy work. And vaccine hesitancy part of it is what we have published in Ideas for India, that how even across different states and across India, how vaccine hesitancy has changed over time, and how whether people are willing to, if not, why they are not willing to take the vaccination, and so on. So just to give a background of the talk, I mean, I had already kind of detailed down the basic two objectives, which are the protocols and then the vaccine hesitancy. But the background of it actually comes during the point when the COVID started. There was since the early phase of the COVID, at least the entire first year, we did not have any effective treatment or neither a vaccination. So, and when during that time, it is the various non-pharmaceutical interventions that were adopted by the country and that was recommended by WHO. So those non-pharmaceutical interventions were something that was highly needed, as a proxy to treatment, right? So adherence to those measures in those crucial time, like, was very important in determining how to keep COVID in limits. And later on, when vaccination came in, that was also important to see that how people are now adhering to vaccination. That means not only taking the vaccination up, but also actually maintaining the duration and taking and diligently following the second dose after the first dose, and so on. So so the first part of the talk, which shows that how individuals are adhering to the COVID protocols over time. So that part of the talk I'll take up, and Shantanu then will come in and will actually detail the second objective, which is to understand the level of vaccine hesitancy over time and across different states. So before I actually go into showing the graphs and showing some of the numbers, I wanted to take this moment to say that many of us who might be using Facebook, you probably have come across this, right? That when you have logged in, you have seen a notification that comes up that start the survey. This is the background, that there is a survey that is going on, and why the survey is important, and how much time that the survey will take, and so on, right? So once you have started the survey, it has taken you through some of the questions which are related to for testing, which are related to symptoms of COVID, and later part the questions kept on revising, and that I'll come to that part. But I wanted to show the screenshot of how you have also might have come across this while using Facebook. So this COVID-19 trends and impact survey, that's the survey that is being called now. But when the survey was actually launched, this was named as a COVID symptom survey. So CSS was what it was earlier named as, because the focus of it was to actually find out where are the symptoms, where most people with symptoms are located, to see the hotspots of those places, and so on, right? Now, the uniqueness of the survey lies in the fact that especially when COVID hit, like in last year, when almost face-to-face survey was not able to, like no one could then think of face-to-face survey, and then the entire survey infrastructure was moving from a face-to-face to telephonic and then to web survey. At that point, actually, University of Maryland and Carnegie Mellon University, in partnership with Facebook, they launched it, and the survey was launched worldwide. It started since April 2020. In India, it started from 23rd of April. And since then, it's still continuing, it's still going, and the survey is actually going on in more than 200 countries and in more than 50 languages. So as I said, that initially it was designed to help monitor and forecast that where would be the hotspot of COVID, who are those who are how many people are actually getting the symptoms, and how to differentiate that symptom, COVID-like illnesses from influenza-like illnesses, right? And how people can actually whether that difference can be identified, and whether and then whether you can actually identify the places where COVID it is now going to hit high. But the recent rounds have been revised. So since then, many of the revisions, so we are now in 11th version of the survey. So many of the revisions actually kept on happening, and with inclusion of new questions being added on the survey. So when vaccination started, then you have questions on vaccination, whether you are getting, whether you are vaccinated, how many doses you are vaccinated with, what are the barriers that you are facing while you are going to take up the vaccine, so all the questions regarding vaccination, economic security, mental health, those questions also on started coming in the rounds of the following rounds of the survey. Now here the arrangement that have the University of Maryland and Carnegie Mellon, they are the academic partners and Facebook is the platform. So Facebook does not share any background information of the respondents with the academic partner, and in turn UMD and Carnegie Mellon, they do not share the survey responses, so they do not share the micro data with the Facebook. Now when we got to know that a survey of of such a magnitude that is happening, then at NCER we entered into a data use agreement with University of Maryland to be so that we can get access of the micro data. So now you can understand that when the survey is running in 200 countries and 50 different languages, we wanted to extract, to start off with, we wanted to extract only the India part of the sample. So the team, NCER team, has worked on, and from the millions and millions of responses, so what we are currently working on is the India version of the Indian sample, and which was launched on 23rd of April 2020, and it's a daily repeated cross section. So the survey is happening every day, and as of 3rd of September there are 2.5 million survey respondents. Here I would like to mention one thing, that even though you have 2.4 million survey respondents, but not everyone has responded to every questions, because it was self-reported. So people have kind of moved, and have not responded to certain questions and moved to a different question. So you will find, a difference in observations for different questions. So I have kind of already said that what the survey mostly consists of. So it's mostly consists of the self-report COVID-19 symptoms, and then also experience with the COVID test, and then also of course inclusion of the COVID protocol questions, mental health, security, and vaccination questions. So just very quickly on the methodology, here the sampling frame is the Facebook active user base. So all of us who uses above aged 18 plus in India who use Facebook actually consists of the sampling frame. And the study design is a repeated cross section. So there could be repetition of survey requests. That means I can get, I may have filled in the survey, but a few months down the line, I might have also got the request again. So if I fill in that survey again in the next round, then my sample will be considered as a new sample. So I'm not in the longitudinal frame where my sample is a panel. So my sample will be treated as a new sample. So that's what the study design is. And they have actually followed a stratified random sampling, where the strata being the states. And the important thing here is the survey weight. So when you get the micro data from the data partners, right? So when you get the micro data, they have the weights, which also provide the weights, and the weights are computed such that it represents the general population. So we have some details on the survey weights, but during the discussion, if it comes up, then probably we can go a little bit deeper into it. But for now, I'm just leaving it as it is, but we can discuss later in detail that how Facebook, actually from the Facebook user sample, we came like the weight that we see actually represents the general population. So then coming into the fact that who are the respondents. So as I already said, that the sampling frame is a Facebook, like Facebook users. But in terms of in terms of demographics, so we see that of course like percentages, 50% of them fall in the age group of 25 to 44 years, and we have 65% of male in the sample, and there are, and most of them are from the city. So the categorization that we see is village, town, and city. So we see most of them belong from the city. Now there are two things here I would like to mention. One is the education variable. So the education variable right from the beginning was not properly coded in the microdata. So we even though we wanted to, we could not use the education variable, and some other variables that were introduced later part in the survey were the occupation variable. But even in the occupation variable, you do not see, you see most of the clusters are in the categories of others, so you do not know who are those others. So there's not much point in using the occupational variable. But here, when we started using the data for the first time, and then we had an opportunity to present this in front of the global Facebook team. So there, this point was raised that the education variable was not coded in the right way, and it might be the data users will not be able to use that properly. And so in the recent round, which is in the 11th version, so the rounds that we are seeing of the data now, that's where education, they have like changed it. And now, in the following rounds, starting from August, September, that now it's possible to include education as one of the demographic variable even in the analysis. So I wanted to then come into straight to the objectives that we have for today's talk, which are the how have people adhered to these protocols over time. So basically, before the vaccination came, it was mask use, hand washing, and the social distancing. That these three were there, and then we wanted to see that how that kind of have changed over time, right? So I'll start with mask use, and I'll also as I go into the graphs, I'll try to explain what actually the question that was asked and how we have used that. What are the trends that we are able to see from the variable, from the variable that in the data. So before mask use, like I wanted to show this. This graph talks about the mobility, right? Like in the y-axis, in the x-axis, you will see I have plotted the months. So it started from May 2020. So April, the survey started from April, but April had a very small sample size. So it started from May 2020. I've shown it from the May 2020, and then you have you go into till August 2021, and here so you will see that the way they have asked this question is that in the last 24 hours, have you done any of the following, right? So have you gone to work, gone to the market, restaurant, spent time with others, attended any public event, or you attended any public transport? So as you see, even right from the beginning, so if I show you the months, so this all dots are the months, and my curves, so the lines are the different activities. So for example, this is my activity is going to the restaurant or not. So it's not surprising that you see that for most of the respondents, it is going out for the market. That was a necessity, even though if not many of them have been able to avail the online services. So going to the market was something that was necessity. So that's where you see the highest percentage of the respondents, and that kind of stayed through over the time. Like going to the market, the mobility is highest for the activity which is going to the market, right? And then second, it is going for work. But interestingly, you see, I have given a short like a timeline just to reflect on that October 2020, when the cases, actually the wave 1, the cases actually started coming down straight for 3 weeks. The cases were going down in India, and that's what the time which was also the festive time all over India. You see, going to the restaurant and attending public event kind of started picking up. So the slope has actually started increasing right from here. And just when this is a time of the February and the March, just when the cases started rising, all the activities depending on irrespective of going to the market, or all the activities actually went down pretty much. And going to the restaurant and attending public events which were not the necessity ones, that dipped the lowest. And after we are slowly moved away from May, like in the June, July, August, it kind of again started picking up, like the activities are starting to pick up. So after this question, they have asked that, for all these activities, whether while you have gone for work, if you have responded yes, that I have gone for work, then they have asked that, well, whether you have used mask or not when you have gone for work, right? So in the next figure, what I showed is that you will see that these are for those who have these are those who have actually gone for used mask while doing those activities. Now, this is also interesting here that probably mask use is mandatory in public in workplaces. So hence, even after wave 2, that means now in the August, in July, August, June, July, August, you see kind of we are almost in a similar benchmark, even during, like, the mask use after wave 2 and mask use before wave 2 are kind of stable. But for the going to the restaurant and for attending public event, you see for these 3 activities you see a sharp decline. Now here I also wanted to point out that the scale does not start from 0. So even if you see this drop is literally drop from 80% to somewhere between 60 to 63. It's not like going down to 0 or anything. But here there is one like point that also needs to be acknowledged, that remember this, even though this is in percentages, but this question was asked like the restaurant, whether you have gone for the restaurant using a mask. This question will be asked only to those who have said yes in my previous question, which is my previous slide, right? So that percentage of people are really less. So maybe because of the sample size, the dip is also seen, even though this is a percentage, but because of the sample size, this dip can also be seen. But interestingly, moving from this 24 hours question, they have asked that whether you used mask all the time in the last 7 days or not, right? So in the last 7 days, whenever you have gone out, whether you have used mask all the time or not. Now here, it is not about the different categories. It is not about that whether you have used mask for particular activities, but I have plotted here the age group. So these 4 lines are 4 different age groups across months. So that means for in October 2020, for an age group 18 to 24, this is the my amount, or my percentage figure is. So a couple of things that we see directly here is the use of mask among the younger age group has always stayed consistently below. The percentages stayed consistently below compared to the other my other age group. And now for 45 to 64 and then for 65 years, that this 2 age group have the highest mask use. That's what we see from the data. Now, if you see very closely, just before wave 2 heated, now this was a time when the October, again the festive time, so you see the mask use for almost all the age group was kind of going down. And then the wave 2 came in, so starting February the cases started rising, and then the peak is in April. The mask use is highest in April, and we do a similar, very similar trend of what we had seen in pre-wave 2. We had seen a very similar trend also in the recent times, in the months of July and August, that the mask use in for any kind of activity is again coming down. Then this is just a snapshot of 4 different states which we consider probably important and can be looked upon. Even though Maharashtra had a very Maharashtra has always a very high COVID cases, but we still see Maharashtra had a very volatile kind of plot of mask use. But again, Maharashtra's COVID peak had came, even the second wave actually heated a little before than say even in the national peak, and also for Gujarat and for other states, right? So you see the moment the peaks, the cases were rising, the mask use actually went up, and then again it kind of started coming down. Gujarat almost had a very similar flat plateau, kind of very equal percentages of respondents in Gujarat have responded to the mask use that they are using masks. So that's almost very uniform across. It's only other than Delhi, we see in Kerala, in Gujarat, and also in Maharashtra, the usage of mask is coming down. But in Delhi, we still see there is the graph is on a higher trend. Then I go to hand washing behavior. And I spent most of my time in the mask use because the mask use questions are very have been followed through across the versions and have been followed through properly. Hand washing behavior questions like CTIS, the Facebook data, does not do a very good job in the hand washing questions. There were one question which they had only continued for 3 months after they began the survey. That means whether you often wash your hands or not at all, or sometimes, which they discontinued in June 2020. And then starting June 2020, they had actually started using this question, which is in the last 24 hours, about how many times have you washed your hands with soap and water or used hand sanitizer. This question was also then discontinued after in May 2021. So in the current rounds of the survey, you would not find any of the hand washing questions in the recent survey rounds. So I would not delve too much deeper because there's not much to say here, but to still find a similar trend if you look closely into the months of April, May. It is that the 7 or more times, the hand washing 7 or more times, that number you see is increasing. That percentages you see are increasing at least 3 to 6 times and 7 or more times. That's what we see higher percentages in the recent months. But as I said, that not very much significantly can be talked about, particularly about hand washing. Now going to the social distancing questions. Here, there are 2 questions that are being asked. So one is, how often are you intentionally avoiding contact with other people? So this is the only question that is running till now. So the Facebook had started asking this question starting November 2020. So November 2020 is when they first asked this question, and then this question is actually continuing now. But before that, actually, and there was this another question on social distancing, which was, in the last 24 hours, how many have you had a direct contact with anyone who is not staying with you? So that was a question that they discontinued after May 2021. So I'll come first on the right side of the figure, on the right figure, and then I'll come back on the intentionally avoiding contact question later on. So if you see on the figure to your right, on the direct contact, there also you see a very similar pattern, that after this May 20, like during the time when when the cases have started rising, direct contact among people have actually gone down pretty much, even though it is increasing a little bit like little bit after May, but it stopped. The question got discontinued there. Whereas how often are you intentionally avoid contact with other people? You see almost all the time you are intentionally avoid contact people, is you also see a trend very similar to what you would expect in this month. So in the months of May, in the months of, so right from your February, March, April, May, that's when you were intentionally avoiding your contact with other people, which is now again going down. And you see that none of the time, which is you are not, almost none of the time you are intentionally avoiding contact with other people, that percentage is slowly picking up. So what I, just to summarize what I showed up until now is how the mask use behavior changed, and what do we see in terms of hand washing, and how did people adhere to the social distancing norms. Now there is, in the very recent rounds, when all the graphs that I had shown you was till August 2021. So in the recent round, so which is this in the last 15 days, which is September 1st to September 15th, we see a belief question. We see that what is the belief about others practicing the norms. So whereas 89% of the people, they think that they wear mask all the time, but they believe that only 48% of the people believe that all or most of the people wear a mask. So it is the first point is about what what they have responded to the protocol, and then what they think that other peoples are adhering to the protocol or not. Similarly, 59% of the people avoid contact all or most of the time, whereas they think that it's only 23% of the people otherwise are actually maintaining the locally recommended distance. And here then I'll bring in the vaccination. The 76% of the people believe that all or most of the people are vaccinated. But what we see actually current vaccination is actually, Shantanu will be looking deeper into that. But I'll just touch that what we see from the Facebook data is that 43.1% is a weighted average. So 43.1% is vaccinated by the time of the survey. And if you difference that between first dose and between second dose, we see 59% have said that they have the first, they have got the first dose, and 39% are in the second dose. Now, the reason that I introduce the vaccine coverage, and as I said, Shantanu will take on the vaccine questions a little bit deeper and showing you the actual statistics. But I'll stop here with this slide. Now, after showing all the protocols and after showing the temporal trends, the question that we ask, that whether it is about following all the norms or not following any, that means someone who is disciplined, as we say, whether they are following all the norms, or versus say someone who is not vaccinated, are they the group who are not even using mask, they are not getting vaccination, they are not using mask, they are not actually maintaining social distancing? Because I just simply did a test where we saw that the vaccinated population has significantly higher mask use than unvaccinated population, and this goes true for the vaccinated population has having significantly less direct contact compared to the unvaccinated population. And also the vaccinated population are the one who are intentionally avoiding contact compared to the others. So I'll end here with this questions, which might be taken up into more detail as we take the work further using data and also using some of the other secondary sources along with it. So Shantanu, I'll pass on. You can. I'll stop sharing and.
Thanks, Soumi. Yeah, let me try to share my screen. You can see my screen, right?
Yes. Yeah, please continue.
Yeah, so as Soumi mentioned, let's delve a bit deeper into the vaccination coverage, because going forward, I think that's going to be the key component in dealing with the pandemic going forward. So let's see how we are doing on that front, and what could be the potential sort of barriers to not being able to achieve the target that we want to achieve. So first, where we stand. So this is the official data obtained from the COVID-19 India.org. So here I plotted the daily doses of COVID-19 vaccination. It's a 7-day moving average. So starting from when the vaccination drive started, that 16th January till date. And you can see a very clear sort of increasing trend in vaccination rate, daily vaccination rate. There was a dip early, so sort of mid-May or something, when the vaccination was open to all adults. I think probably because of shortage of supply of vaccines. But after that, you see a steady sort of increase in number of doses being administered on a daily basis. So I think the target that the government is having now is to fully vaccinate approximately 944 million adults by the end of the year, which means we need to administer about so double the number of doses, right? So 1,888 million doses. And if we want to achieve that in the remaining 100 days, so we need to sort of vaccinate at the rate of 10.5 million doses per day. We are pretty much close to that. We are now sort of vaccinating around 100 lakh doses per day. So we are sort of doing pretty good, I would say, on that front. But the concern is, how are you doing on the completion of doses? Because the evidence clearly suggests that one dose is not enough, and there are sort of concerns around the schedule of doses between the schedule of days, schedule of doses. But that's a separate issue. But even if we accept the schedule that is recommended now, how are you doing in terms of completion of doses? So here I plot, this is a state with the same graph, 7-day moving average, but by number of doses across selected states, which contributed significantly to the pandemic. So ideally, what we want to see is that a cyclical pattern, like when the number of doses, number of the first dose, number of doses which is administered as dose 1, it would increase, and then at a point it should decrease, and at that time point the number of doses administered as dose 2, which is in the bluish color, that should take over, that should cross the reddish color, which is the number of doses administered as dose 1. So we see that pattern. Say, for example, if you look at West Bengal graph, okay, so you see that there is a steady increase of dose 1, then it declines, and at that same time, dose 2 increases. So that kind of suggests that people are completing their doses, and that cyclical pattern is also seen in many other states. Like if you see, say, Delhi, Maharashtra, or Kerala, also you see the similar trend. Like there's a cyclical pattern you see between dose 1 and dose 2 numbers as we move across time. But for some other states, say, for example, if you look at UP and Bihar, you see that there is a steady increase in the first dose, I mean doses administered as the first dose, and increase in dose 2 also, but at a much slower rate, and they never actually catch up. I mean, the dose 2 line is always below the dose 1 line, which kind of suggests that there could be concerns of completion of doses, and that's these two states it's pretty clear. And also that's two other states which we found very sort of problematic in the context of vaccination coverage is Punjab and Tamil Nadu, where we have seen a lot of hesitancy. I'll come to that. So you see that the same thing is happening for Punjab and Tamil Nadu also. The compliance is an issue where the level with the dose 2 line is always almost below the dose 1 line. So to elaborate more on this point, here what we have done, we have looked at the percentage of first dose and percentage of second dose out of total doses given on a particular day. Okay, and since daily doses, it will be difficult to plot, I have aggregated it by month. So in a month, say for example, we started in January. In January, in all states, you would see only dose 1 was given. So 100% dose 1 you see. And going forwards, February, March onwards, you get to see that a certain percentage of dose 2 also are being administered. Okay. And this we would expect to increase at a regular interval, or at least in recent months, because after May, the schedule has changed for Covishield to 3 months as opposed to earlier 4 to 6 weeks. So we see there's an increasing percentage in dose 2 vaccination that's happening in Delhi, in West Bengal, in say Telangana. You'd see there are a couple of months where there is almost 50% doses are administered as dose 2. Same is happening in Kerala, Andhra Pradesh, etc. But again, if you see states like Punjab, Tamil Nadu, UP, and Bihar, the percentage of dose 2 are it's always much lower than even 50% when we aggregate on a monthly basis. So that kind of suggests that there could be issues of compliance, completion of doses in some states relative to others. So this is from CTIS data. So the earlier two graphs I shown, those are from the official data. This is from CTIS data. So here what I have done, the sample for a month. So the sample aggregated over a month. Based on that sample, I have calculated the coverage of receiving 1 dose and 2 doses. So one thing we have to keep in mind, CTIS data can give us the actual the coverage of dose 1 and completion of doses, whereas the official data can only give us at least 1 dose. It cannot actually tell us currently at the population what percentage received only 1 dose and 2 doses. So that CTIS data can give us that. So here this is with time you can imagine that these percentages would increase with time. That's what we get to see. The point I'm trying to make here, the dotted lines, if you see, that's the overall coverage of receiving only 1 dose and receiving 2 doses. So that's fully vaccinated. Okay. So they're in 2 different colors. One is the red color, that's receiving only 1 dose, and fully vaccinated is the bluish color. So you see again the gap between the percentage is higher in say UP, Bihar. Okay, and also say Madhya Pradesh, you would see a larger gap. But for states like say Telangana or Andhra Pradesh, Odisha, etc., Kerala, Gujarat actually. So you see there's very little difference between dose 1 and dose 2. So here we have to understand what dose 1 means. These are the percentage of people who received only 1 dose, and the bluish color represents the percentage of people who received 2 doses. Okay. So basically all 3 graphs kind of conform to the fact that there are certain states where completion of doses could be an issue. So we need to look at that carefully if we want to really protect the population through vaccination. So what could be the potential determinants of vaccination coverage? So they can be broadly categorized into two sort of groups. One are the supply side factors. So we have seen at different points in the past that there is not always there are not enough supply of vaccines, which could lead to lower coverage. Also, there could be insufficient number of vaccination sites, which may lead to concerns of long travel requirement to get vaccinated, concerns of wage loss, crowding at the sites, which in turn can lead to transmission of the infection. And also, I mean, there could be lack of adequately trained staff, which could be an hindrance to increasing vaccination sites. And digital registration system, which I think is with time, I think it has been gradually been we're more flexible on that. There are a lot of options of walk-in vaccination, etc. So that helped, I think, in achieving the equitable coverage. But when it started, I think it was an issue. And among demand side factors, pricing, again, it could have been an issue when it was open to in May onwards. I think it started to have both public and private providers, but with 50% public and private providers. But I think in June, the government has changed the policy with 75% of the vaccines will be procured through public facilities. So that means that's free. It's only 25% from through private providers. So that's a good that's a welcome sort of move to achieve equitable coverage and not making pricing as an issue in the context of coverage. So the other factor which can be and which is sort of is a hindrance towards high level of optimal level of vaccination coverage, that is vaccine hesitancy, which can be loosely defined as, like, even with the availability of free vaccines and no supply side issues, some people may not want to get vaccinated for whatever reason. So that we'll discuss in more detail using this COVID-19 trends and impact survey data. As Soumi mentioned, that the CTIS data, I mean, there are concerns of being representative, etc., because it is based on Facebook users as the sampling frame, but nonetheless, it's a unique data source to study the spatio-temporal variation in different COVID-related indicators, particularly in a time when the traditional method of data collection was becoming very difficult to conduct, and on the other hand, the need for data was even greater. So that's so in that context, I think this is a very useful data source. So now we look at the vaccine hesitancy across states of India. There's not all states, I couldn't accommodate all states in the graph, but these are the states which are relatively large in size. So the question that was asked in CTIS, if a vaccine to prevent COVID-19 were offered to you today, would you choose to get vaccinated? It has 4 options: yes, definitely; yes, probably; no, probably not; and no, definitely not. So the last 2 response options, no, probably not, and no, definitely not, are considered as the hesitant group. Okay. So here we see that for Tamil Nadu and Punjab, we observe the highest level of hesitancy, and this is the combining the sample from end of December till now. That is 3rd of September. That's the latest data we have used. So, and throughout we have seen this continued to be the trend. Like Punjab, Tamil Nadu remained to be the most hesitant among all states, and Kerala and Odisha are the least hesitant among all states. And this question on vaccine hesitancy is asked only to people who are unvaccinated, who said that they didn't receive the COVID vaccine, not even a single dose. So to define vaccine hesitancy, we have excluded the vaccinated people from the denominator. Okay, so there are both way one can define, because one can argue that those who are vaccinated, they can be considered in the denominator. But we thought that understanding vaccine hesitancy in unvaccinated people is more crucial from a policy perspective. So that's how it is defined here. So now, because it's people's attitude towards vaccination is changing, I think, given the dynamic nature of the pandemic. So it is important to see the temporal trend. So here we have plotted the weekly estimates. So the sample has been aggregated, 7-day sample has been aggregated, and the estimate has been calculated just to make sure that the estimates are more stable relative to using a daily sample. So here in general, we see a sort of declining trend in hesitancy till wave 2. Okay, so wave 2 is state specific. Wave 2, we have sort of this red band, which is defined as the peak, the day on which the highest number of cases was achieved, plus minus 1 month around that peak date in all states. So there's a sort of declining trend in vaccine hesitancy till wave 2 we have seen for most of the states. But after the wave 2 is over, many states we see a sort of increasing trend in vaccine hesitancy, which kind of makes sense because, so first of all, so now we are in a better situation in terms of number of cases, and also those who haven't got vaccinated yet, I mean, so more and more people remain hesitant among the unvaccinated people. That kind of intuitively makes sense. So who haven't got it yet, so they probably continue to be hesitant in getting vaccine going forward. So that's what we see, an increasing trend. Also, when we look at this hesitancy by demographic groups, we see the same trend of increasing hesitancy among the remaining unvaccinated population. So that's a worry, and we need to think how one can overcome that. So now, what are the potential reasons behind hesitancy? At least, what are the potential reasons reported by respondents? Okay, so 3 main reasons that we see here. So these are the 2 groups of hesitant. One is the who said no, probably not. They probably won't take vaccine. The other group is the they definitely don't want to take vaccine. So more or less, combining these 2 groups, if we see the 3 main reasons are the concerns of vaccine safety, concerns of side effects, and third one is more like other people need it more than I do right now, which is kind of a sort of social desirable answer of the first 2 concerns. So concerns of vaccine safety and concerns of side effects. So, but another thing we observe is that for the definite hesitant group, there are some other significant reasons, which are I don't need vaccine, I don't trust government, and I don't like vaccine. So these 3 are more significant, more significantly higher compared to the probably not group. And those who mentioned that I don't need vaccine, they were asked a follow-up question: why do you think you don't need vaccine? So the reasons people mention is that they plan to take other precautions like mask use, etc., maintaining social distancing, etc., and also they mentioned that they don't have much interaction with high-risk people or high-risk group of people, etc. So these are the sort of reasons we have seen from this data. So now, as I mentioned, the key concern seems to be the vaccine safety and concerns of side effects. Now, what do people actually think of side effects, or why is this concern? I mean, it cannot be that people are concerned about having fever or swelling at the injection site, right? So there could be some other concerns people might have, because of which it could be they are thinking of more adverse, more serious side effects, which could include death as well. So then we looked at another question that is being asked: how concerned are you for experiencing COVID-19 vaccination side effects? It has 4 options: very concerned, moderately concerned, slightly concerned, not at all concerned. And these 4 colors represent these 4 option categories. And if you look at the vaccine hesitant group, that is yes group, and the no is the who are not hesitant. Okay, you see that people expressing, people being very concerned for experiencing side effects are much higher for the hesitant group than the non-hesitant group. So which kind of suggests that they are not really thinking of fever or pain at the injection site or swelling at the injection site. They, that don't reflect that level of concern. So it could be something else they are thinking, which may come from one of stories they have heard. It may come from a, so it may suffer from a sort of small sample problem, because people get to hear different stories from their circle, and that may have contributed this level of concern to this level of concern that people are experiencing for particularly for the hesitant group. So now, vaccine hesitancy by demographic characteristic, there's not much to say here, not much difference we have seen across different demographic groups. It's more or less the same pattern by gender, by age group, and by area of residence. The general trend that is like it's a steady decline in hesitancy, level of hesitancy till wave 2, and after that there is a steady decrease in level of hesitancy among the remaining unvaccinated population. And when you look at different age groups, the same pattern we have seen, except for the last 65 years and above age group, where we see a steady increase in hesitancy level. So here, my sense is that this could be a group of people who may have different health conditions. So, I mean, whoever got vaccinated, it's okay, and who haven't get the vaccination yet, they may not be willing to take the vaccination given the health conditions they might have, given the age group. So that's the sort of, we need to explore further to find out about this high level of hesitancy in this group. Again, by this area of residence, city, town, village, we don't see much difference in the trend. Okay, so now just the summary slide before we open up for more discussion. So, I mean, what we have seen from the very beginning, when this vaccination drive, the guidelines have been developed, there's not much emphasis on the vaccine hesitancy component from the beginning. There are more emphasis on ensuring that all the supply side issues are taken care of for a smooth vaccination drive. Not much emphasis on the vaccine hesitancy part. That some effective communication was perhaps missing from the very beginning. And also this, as I said, this safety and concerns of side effects are the biggest contributing factor. So it would be useful to deal with this with data. Like now, as this the Facebook data, CTIS data doesn't collect any information from the vaccinated people, like what side effects they actually experience. If that data was available, then we could have used that to counter this level of concern people are expressing for the vaccine safety or concerns for vaccination side effects. If we could have used that data to counter that the side effects are really minor and the severity is really mild. So that data is not available, and also the AEFI system we have, it doesn't look like a very robust AEFI surveillance system we have. So I think building a robust AEFI surveillance system and transparency and reporting and timely investigation can help in building trust. So I was attending a talk recently given by the Immunization Technical Support Unit of the Ministry, and so I was asking like how this AEFI reporting is done. Is it being reported by the individuals who receive the vaccine, or it's done at a very aggregate level, etc. And they're thinking of sort of introducing a system where individuals can report AEFIs, like they would be sent reminders through SMS after they get vaccination. I think that may help in getting more transparent data to get a sense of actually. So I'll stop here. So I'd like to acknowledge the team's contribution also, like Abhinav, Vijay, and others. They played an instrumental role in extracting the data, because as you can imagine, it's a huge data set, and it's a world level data. So to actually extracting the data in itself was a challenge. So I'd like to acknowledge that. I'd stop here, and if there are any questions.
Thank you very much, Shantanu, and also many thanks to Soumi. I think it's very clear that we can see the power of big data. This is one of the shining examples of how one might be able to leverage big data, and that too using continual real-time reports, where perhaps the possibilities of using the results of analyzing these for making even weekly or daily tweaks to the efforts being undertaken to combat the pandemic, I think are quite obvious. So this was very interesting and very helpful. Thank you very much. I have, I think, two major kind of questions. What I will do is I will ask one, and then I will open it up to questions from the audience, and then time permitting, I might get back to the other. So as a public health person, I suppose I am most curious to get your views on the population to whom you think these conclusions are applicable. To whom can we generalize these findings? Who do you think your sample represents? That is my question. Actually, please go ahead. I can save the rest for later.
Yeah, I think that's a pretty valid question, and it actually we also, when we started using these data, the first few couple of months, actually, we spent time on understanding the representativeness of data and the weight they have constructed, as Soumi was mentioning in her talk. So basically, there are two levels of error can happen. One is that those who were sent the survey request, all of them won't respond to the survey, right? So, and they are usually the respondents and non-respondents, they're always very different in terms of socio-demographic characteristics and possibly in terms of outcome as well. So then how to go from this, how to overcome this non-response? And then the Facebook users, from Facebook users, how to go to the general adult population of India. So they have done two stages of weighting adjustment. The first stage, what they have done, so for Facebook users, Facebook has a lot of data on all of us, right? All users. So they have used that data to construct. They have used this inverse propensity weighting method to assign a sort of propensity score of responding, and then use the inverse of that as a weight, non-response adjusted weight. But we don't know what user characteristic they have used. They didn't share that information with us. Okay, and then from Facebook users to general population, they have done some post-stratification adjustment, but they have considered only two strata. Actually, the slide Soumi had at the beginning on the respondents, we should have another column with the weighted percentage to see how those, because Soumi, you remember you mentioned that the younger population is 52% for one particular age group. After using the weighted percentage, it would be useful to see how that changes, whether it's kind of matching with the census percentages or not. So they have used two post-stratifying variables. One is the age group, 4 age categories, and gender. But they haven't used the urban-rural as post data. So I'm sure there would be a huge difference. So it may not be representative for rural population. That's a concern. And also for age group and gender level also, if we think, it varies across states. We have seen for some states it's matching up very well with the census counts, the weighted counts. But for some states like Bihar, say women from Bihar, it's not at all representative. So there are, I mean, definitely there are concerns. Yeah.
Just a quick follow-up. Thank you for the clarification, Shantanu. But I was also thinking in terms of the digital divide, and we know that the total numbers of Facebook users may not necessarily represent those who are savvy about its use, and those who may, then there is the next layer of those who are interested / comfortable in responding and so on. So I know that when you were thinking about these multiple layers as you were speaking, but the biggest concern for me seems to be the sadly the lack of comfort I have in taking these conclusions and applying it to, I don't even know what to call the general population. I mean, I don't know to whom I may be able to generalize this to. Yes, predominantly urban, tending towards the younger population, more male. I remember these three factors that were mentioned earlier. But when we think about perhaps the financial status or the other forms of socio-demographics, it would be helpful, even if you don't want to respond right now, to think a little bit more about to whom this may be applicable, and then think a little bit more about if these are the findings we have from such subgroup, and no doubt it's a large subgroup of, let's say, the Indian adult population, what might we expect in those who are not on Facebook, right?
Yeah,
At least
no, I
based on
think
other
that's,
studies in folks who have not gone the Facebook route, there may be some information there. Or we might want to think of at least speculating along those lines, to at least think of, mainly in terms of what are the boundaries regarding how far we can take these conclusions and how might it change. Of course, it would be educated speculation at this stage, but that is what we would benefit from, given that you guys have taken such a deep dive into these data. So please go ahead.
Yeah, no, I think that's a very, useful suggestion to think through those lines and along those lines, and think of how these estimates can be modified, or is it underestimating or overestimating depending on the outcome? Those we need to think through. But I think it's most the more usefulness of these type of data is to see the temporal trend or compare the spatial variation, because that's you are sort of comparing the same Facebook users across states and same Facebook users across time. So at least that way it can be used definitely. But yeah, but to draw conclusion about the population at a time point, it may not be possible.
Yeah, and I just want to echo what Santanu said. So yeah, when we actually got the data, the first 3 months was almost on like being comfortable among ourselves that we can present this and portray this as a as a targeted general population, and how to go about saying that this is the way that would do. And in say our team, what we were trying to do is that, so we were trying to take the weight what Facebook gave us, right? So the weight that we see in the micro data, but and also going through each and every state to see that, well, even applying this weight, the female population and the male population, it does not representing on what should be there in Bihar, right? So what we had then gone back to the global Facebook team and requesting them that, well, if you can give us some other parameters from your data source, unidentified data, so that we can actually create the post-stratification weight ourselves instead of depending on the weight that you are giving us. Because the limiting factor in this case is just because we are limited with the, we wanted to do with the education variable, but that's why I brought it up earlier, that education was kind of completely not a usable variable. We wanted to do it by the occupation, but occupation was also introduced in the very recent rounds. So the only age, gender, and then the city, that's the three things that we were left with. But yes, the team actually would be interested in doing the stratification ourselves to actually come up with a weight so that we can more confidently portray this as a general population thing.
Yeah, and the other point, even if the demographic, another limitation of the data is, even if the demographic variables that they have, those were collected at the end of the survey. So there are a lot of missing, even those who responded, they didn't even responded to the
they just skipped.
demographic. They skipped. So there are a lot of missing for these demographic variables also, which also limits our validation process as well. So
True.
Because we wanted to see that, well, we understood that, well, people will not be responding to, say, a COVID tests questions, but then coming to the end, they would definitely respond to age or male.
Right.
But even there also, if our total sample is to 2.4 million, that was like reducing to 1 million because people are even not responding to the demographic sample.
Yeah, people, I'm guessing, can get distracted on Facebook, and then they have to answer all these questions which are not about a celebrity or what clothes their babies are wearing. Sorry, just one quick point I'd like to make is, please think about whether it is even possible to generalize to the adult population, or maybe it is possible to say that this is the kind of subgroup that we may want to think of. But I don't want to beat this point to death. I invite questions from the audience, please. You may choose to share it over voice or on chat window. I will be monitoring that. Please go ahead. Yes, Satya, please go ahead. Share your questions. So I already see that there is one question on the chat, which is there an effect of the national lockdown during May 2020? This is from Sandeep Agrawal. Sorry. Sandeep, would you like to elaborate? Is this the effect of the national May 2020 lockdown on any particular outcome you were interested in? Please go ahead. Soumi and Shantanu. Oh, sorry, was Sandeep? Sandeep, please go ahead.
So I had a couple of observations and a couple of questions. If you can.
Sure. Please go ahead, Satya. Please go ahead.
So, like, I've realized over my time in research that big data has two effects. Like, one, it dispels some myths, and one, it reinforces some myths. Like there were a lot of politics around this data during the COVID times or post-COVID times, especially pertaining to a few social groups over newspaper reports and over various media articles. So, like, I was wondering, especially, so I was wondering whether, I mean, how this COVID protocols, how this study which talked about COVID protocols, vaccine hesitancy, how it could it dispel these myths or could it not dispel these myths? I mean, there was a lot of targeting which was happening. I mean, in over the past few months regarding certain social groups. That was my first question. Like, could this because this big data which pertains to, I don't know, quite a few lakh people. So can this data or can the findings of this data help in dispelling certain myths which got created? My second question is, I stay in Ahmedabad, and in Ahmedabad just recently a notification was passed which said that no person could enter a public or use a public facility without getting vaccinated. So like I was looking at Shantanu's presentation regarding vaccine hesitancy. So how would this kind of an enforcement measure, which which is compulsory, like you cannot use a public service without being vaccinated, how would you put this, or how would you rate this in dispelling this vaccine hesitancy question? Like those were my couple of points that I had. I mean,
Yeah, I think it's it's difficult to answer the first one about targeting.
Actually,
And
I have a request. I'm sorry if about my ignorance, but I'm not sure what this targeting of social group Satya was referring to. Shantanu, if you understood, could you please share with those of us who have missed that particular news item?
uh,
Satya, please go ahead. If
so
you have,
basically, at least in Ahmedabad, at least we've seen that, like, there's this thing like Muslims have high vaccine hesitancy, or like, like those kind of news reports which targeted these groups. Like that's what I was pointing to. Like, I mean, and
yeah.
that has been across, like that has been consistent over here. I mean, if you've seen newspaper reports and stuff, that's all I was.
Okay, great. Thank you, Satya. Shantanu, please go ahead.
Yeah, no, I mean, it is quite possible that there are some influence from the government on the how to conduct the survey, because if Facebook is doing such a big thing there, because we have seen few things which like there was a response option in the vaccine hesitancy question. The reasons behind hesitancy: I don't trust government, so that was dropped in one round. Okay, and then again it's back in another round. So but the explanation that was given to us was it was dropped, it was a mistake, inadvertently it was dropped. Okay, so it's hard to comment on these things, but regarding privacy issue, I think Facebook is very particular about it. They themselves don't have access to survey data. Okay, so they also can't share any user information with neither the University of Maryland, who is conducting the survey, nor the users like us who are using the data. So they don't, at least that's our impression by talking to them over a couple of meetings where we have requested the user information for research purpose only, but they haven't agreed to share that at all. So on the maintaining the privacy of users, it seems like they're very particular about that. But I can't comment on the targeting or political influence as such. But coming back to your next point on the hesitancy and the mandatory vaccination, etc. I mean, I'm personally not in favor of that. I think it should be more based on effective communication strategy. That was completely missing from the beginning. That become an important factor, I think, later in the phase, because at early stage the focus was mostly on the ensuring the supply side issues, to how to smooth out the supply side issues and arrange for such a massive vaccination drive. Not much focus on reducing hesitancy. That was never was in the equation. That's our understanding. And also I have concerns about this AEFI reporting. So those things should be improved, I think, and then people would take it up on their own. I think, I don't know, that's my opinion.
What is AEFI? Sorry, I couldn't.
So adverse events following immunization. So this is a standard sort of protocols for even for childhood vaccination. This is in place. That whoever is experiencing any adverse events following immunization, that should be reported, and there's a committee which investigates that, whether that adverse event is actually because of the vaccine or some other reasons. So there are concerns about of underreporting of such events. So that's a concern.
Soumi,
Great
would you
job,
like
both
to
of
add
you.
anything?
Yeah, even in the vaccine hesitancy question, just like there is a little bit on the religious thing, because when they are asked that why do you, for someone who is telling that I do not want to take a vaccine, Then among the other series of options, there is one point where they say that it is against my religious beliefs. So there is a little bit of opportunity for us to explore that. But even though we have seen that, it did not come up as a very high percentages in our analysis compared to the side effects. And it was, if you remember, in the early especially I remember a Hindustan Times reportage in the early in the first wave. So when they say that Indians have this tendency of pehle aap, and and that's what is also one of the options in the vaccine hesitancy, that let someone else take and I'll take after that.
Not being early adopters.
Yeah.
Right. Satya, you were asking something else?
No, I just want to say it was a great presentation. Like, I mean, congratulations to both of them. Like, that was what I was going to say. I mean,
yes.
Thank you so much.
Yeah, absolutely. Very interesting and very nicely laid out. And the way the data were presented visually was very helpful, made a lot of sense. So that was definitely, many congratulations to both of you. Any other questions? I don't know if you would like to take that question which Sandeep asked. I'm not sure if he's still here, in terms of any effect of the first, the beginning lockdown, the May 2020 lockdown, which I suppose began somewhere on March 22nd, if I remember correctly. If you'd like to say anything about that. Meanwhile, I invite other questions as well. Please go ahead.
So, since the first lockdown started in March, right, and then as I said that the data started, the survey started on in India on April 23rd. So after April 23rd, May 1st is the first round of data that we would get. And therefore all the percentages that you see in all the graphs is really coming from towards 0% to going up from May. So we do not have the any information beyond before May 23rd. But yeah, we do see at least the percentages were pretty low in May, if that's what the effect that we would expect to see, and then it is picking up as time was going on.
Right. Yeah, thank you. Of course, difficult to talk about effect if there is no data from earlier. Absolutely. Other questions from the audience? Okay. If not, I see that we have a few more minutes. So maybe I will ask this other question that I had on my mind, which was about perhaps ways that you can show the audience the credibility of these data, especially in terms of social desirability. I mean, when every time you make a phone call, you get a message, that, so social distancing, mask pehniye, ye karo, wo karo, and so on. And then the survey on Facebook says, have you been using masks, and so on. I mean, it's easy enough to see why there might be a pressure to say yes. And yet, of course, there are several people who have responded without a yes. So just to give us a sense of how you have thought about it, to what extent there may have been an impact of what we term social desirability, or that would be another limitation of relying on self-reports. I rely on self-report all the time in my line of work also. So I understand the need for it, but it would be helpful to hear your thoughts on that. Please go ahead.
Yeah, in the context of social desirability, I tend to differ a bit on this, because I would expect more social desirability when the data is collected by an interviewer, because you want to report something that what interviewer wants to hear, or what is socially desirable for others to hear. But on self-reported surveys, it's more likely to be less, but I don't know, there could be other fear and concerns which may have contributed different responses. But yeah, so that's always possible. But if we compare this survey being conducted by an interviewer, I would expect more socially desirable answers than self-report. reported answers.
True, I agree. That's quite valid. But what were the other concerns that you mentioned, if not social desirability?
I mean, that could be political fear and other things. So I don't know. So
Right.
yeah.
Right. Yeah.
Yeah.
Soumi, you wanted to say something?
Yeah, like from what we know, at least about the different modes of survey, since it was the web survey, probably we would expect that the social desirability, since I'm responding to a web survey, even telephone survey, it would be higher because I'm responding to someone. But in this case, I would think that it is less. But here the concerns are actually what Shantanu said. The concerns are, I would think the concerns are with those missing observations, because if you see the vaccinated population, and especially if you actually divide that by doses by month, you will find that actually there is a higher percentage of people who is responding the vaccinated, like compared to what you will see in the national level. There is a pretty high percentages that you will see in the Facebook data. So it seems that, well, it is a vaccinated population who is actually taking up the survey, or is it is probably those who are not vaccinated, they are not responding, they're actually moving down, they're not responding to that question. So what we are left with, so if I was trying to do say the dose 1 and dose 2 difference from the Facebook data, and I would end up only with 4,000. Even from a millions of survey, I would just end up with thousands, because all my others are not applicable, or -99 or -77, which I would have to code as missing, right? So then I do not know that, well, from that little bit of percentages, it does not make sense to come up with that number. I hope that others would have also responded, so that I could actually get one figure. So I think that to me is the most concerning thing in this case.
Yeah, absolutely. Of course, that makes sense, especially when you're thinking about the data about the vaccine, whether they received it or there was hesitancy. So I did notice that even among those who reported not getting vaccinated, the extent, or I think the proportion who said that or who are identified as being hesitant did not go beyond 30%. Right?
Yeah.
I think it started at somewhere 20%
Yeah.
and
30 to
moved up to
40.
some
Yes.
30.
Yes. Yeah.
So for me, the cause of concern is that even among the unvaccinated, more than 50% of the reason for not getting the vaccine seems to be maybe something else. They didn't even say that it is one of the concerns related to vaccine hesitancy. So yeah, of course, it is natural to expect that over time, as more and more people are getting vaccinated, only among those who are unvaccinated, the proportion of those who are hesitant will be higher. That makes sense. But it is also concerned that I am surprised that it is not greater. That means there are so many other factors that are probably playing a role, and a major role, looks like, because more than 60% of those who are not vaccinated have not reported vaccine hesitancy as they have not reported vaccine hesitancy. I don't know if that was worded as why are you not taking the vaccine. I'm not sure. I forget about that. What do you guys think?
Yeah, no, I think the general concern that Soumi mentioned, it's kind of linked to what you mentioned at the beginning, like the digital divide. So it could be
Right.
the people who are sort of using digital devices, they are taking the survey, and it's easy for them to take an appointment, get vaccinated, etc. So that concern, I think non-response is a bigger concern here. Yeah, I agree.
Okay, so yeah, maybe that is kind of skewing the kind of picture that's emerging. So definitely something to think about. I am mindful of the time. I see that we've hit the 6:30 mark. Madhumita, what do you recommend?
Yeah, I think, since there are no more questions from the audience and it's past 6:30, it's almost 6:40, we can bring the session to a close. But I really enjoyed the talk, and I would like to thank you, Malavika, for this wonderfully moderating the session, for your comments, and the speakers, of course, Soumi and Shantanu. Thank you so much for coming and giving such a wonderful presentation. We had quite a sizable audience, and which just indicates the interest that is, your talk has generated. So thank you, and I thank the audience as well for being there till the end. I just want to read out this message from Sonal Day. She said, sadly, I need to leave to get into a call with one of my students. US Day is just beginning, but enjoyed the talk. So she had to leave. Okay, thank you.
Thank you, Madhumita, and thank you, Professor Malavika, for this opportunity
you
and a
for-
wonderful discussion.
This was really very good. Thank you, Madhumita, for having me. And thank you, Soumi and Shantanu. Look forward to all the detailed analysis and papers. Super interesting. Thank you.
Thank you.
Bye.
All right. Bye-bye, everybody. Many thanks to the audience.
Bye.
Bye, Madam. Bye.